So we can go ahead and get started.
Okay, well, welcome everyone. Thank you for joining us on this Tuesday following our 3-day weekend. Yeah, thank you, because sometimes those mornings are hard to get started, but we're very excited that you're joining us, and we're very privileged to have Dr. Cliff Sung with us in the program as one of our fellows and presenting this morning on our Tuesday morning palliative care grand rounds here at UW. So welcome, Cliff, and thank you again. Cliff is coming to us from a pulmonary critical care fellowship. So we're lucky to have him also joining the ranks of hospice and palliative medicine providers. We need all the help we can get, and having clinicians from different backgrounds, I think, really enhances our specialty and makes our specialty special in many unique ways. So I am going to turn it over to you, Cliff, so we can learn a little bit more about palliative care and chronic lung disease.
Thanks, Annie. And hope everybody had a nice long weekend. And you can see this okay?
Oh, yes. Looks good, Cliff. And I just wanted to say I will monitor the chat for you. So sometimes it's easier to have someone help with that. Did you want me to bring questions to your attention as they come up, or closer to the end?
I have a lot of slides. I'm kind of worried about getting through them.
Okay. Okay, we'll save questions for the end, but I'll keep an eye on the chat. So feel free to put comments or questions there.
Awesome, thank you. So yeah, I decided to talk about palliative care and chronic lung disease today. And with the pulm crit background, I was a little torn for a little bit. I wasn't sure if I wanted to talk about crit care stuff or pulmonary stuff, but I think in this venue we hear a little bit more about some of the ICU integration in palliative care, but the pulmonary stuff, I've kind of been learning a little bit about it on my own in the last few months, and I think there's a lot of unmet needs there. I think there's a lot of interesting research, and I think we hear a little less about it. And so I decided to talk about it for Grand Rounds today. Starting with a quote. So, there's a lot of, on the pulmonary resources, websites, and various foundations and support groups, so there's a lot of these like patient stories and patient narrative quotes that I always find super helpful. I think in reality, I think it's very difficult for us as providers to really truly understand a patient experience and what people go through. But these quotes, I think, always help convey kind of that experience. So I've scattered a couple of these throughout the talk to kind of break it up. I have no disclosures for the talk today. As far as my outline and some objectives, I split it up into 3 main sections. So the first is kind of the scope of some of the issues in pulmonary disease, scope of the needs within palliative care. So I'll talk about things like disease prevalence and utilization and access to palliative care, symptom burden, things like that. For the second part, I kind of wanted to shift gears and talk clinically about some of the treatment options, how we treat patients with chronic lung disease from a palliative standpoint. Talk about some of the options there and some of the evidence. And then in the last section, I was going to talk about sort of guidelines and framework for trying to integrate care, so care models and different delivery models. So as far as the scope of the issue, so getting into some of these numbers, I think these are always a little astounding. So this is from NIH. This is 2016 data. And COPD is the 4th leading cause of death in the US, COPD alone. And, it's usually heart disease, cancer is 1 and 2. And then I've seen chronic lung disease sometimes as 3, stroke, and unintentional accidents as the next 3. They kind of go neck and neck. So somewhere between 3, 4, and 5. And in the last couple of years with COVID also, COVID is by itself the third leading cause of death in the past 2 years. So if you lump that in with lung disease, definitively the third leading cause of death in the US. There's over 15 million people who have COPD, and there's an estimated 12 million more who are potentially undiagnosed. And to put that in perspective, I was kind of Googling conditions that may have similar prevalence. And coronary artery disease is estimated at 20 million Americans. So potentially more people have COPD than coronary artery disease in the US. Here's a figure from CDC on chronic diseases in America. So 6 in 10 adults have one chronic disease, 4 in 10 have 2 or more. And then it lists these 7 causes of the leading causes of death and disability and drivers of $4 trillion in healthcare costs. And again, big ones: heart disease, cancer, lung disease is there, stroke, Alzheimer's, diabetes, and chronic kidney disease. Now, I actually thought this figure was really interesting to look at from a lens of like palliative care access. And so, at our institution, at least, we've built some really phenomenal kind of access points for palliative care delivery. And so I think of Dr. Kang, who's now in the Heart Institute, and she's also in the brain and memory wellness area. Obviously, our Fred Hutch presence. And also we have palliative care access for oncology down at Harborview. The stroke clinic, the long-term follow-up clinic that Dr. Wiseman and Dr. Lamb do at Harborview seems like something amazing that we have here. And likewise with chronic kidney disease. And I understand Northwest Kidney Group also has a really good palliative presence. So, of these, aside from diabetes, which I suspect we probably won't ever have a diabetic palliative clinic, but to me, in my opinion, chronic lung disease still kind of lags behind for whatever reason, as far as palliative care access, palliative care referrals, maybe from some under recognition of needs there. So it seems like there's a lot of needs there still. Within the pulmonary world, I kind of made this graphic just to split up a lot of different subtypes. COPD is obviously our big offender, but in Seattle, as a big referral center, a center of excellence, and a transplant center here, our VA is a transplant center, we obviously see a wide variety of these and a lot of different pathophysiologies, but it's really not uncommon to see our ILD patients in the hospital with flares and decompensated pulmonary hypertension, patients waiting for transplant. And I think for this talk, I probably wasn't going to delve too much into the details of disease-specific type physiologies. My hope is for this to be very much a palliative care talk, more so than a pulmonary talk. So let's look at some access issues and some data. So use of palliative care in patients with end-stage COPD receiving home oxygen. This was, I think, maybe 2014 or so. Nationwide inpatient sample. So this is big data. This is a big database nationwide of everybody who's admitted to the hospital, or a good percentage of them. And 182,000 COPD patients they looked at who were admitted to the hospital with an exacerbation. And these were sick COPD patients too. These are patients who are dependent on home oxygen already, admitted to a hospital. And the authors looked at the rates of palliative care referral for these patients. Now, the red line is cancer, and so they use that as a comparator, and the dotted blue line is the COPD patient. So, in general, across the time period, it was a 6-year study. You definitely see an increase in the trend, which is great. There's some increased recognition or acknowledgement of palliative care services. But if you look at these numbers for COPD, we're in like a 1%, 2% range here. So I would say kind of dismally low, again, for patients who are dependent on oxygen admitted to the hospital, so quite sick patients. This is some local data. This is from Crystal and Randy and company several years back. This was a study that was done in the Seattle area, 15 different ICUs, and all patients who died in the ICU. And what they found is COPD and ILD patients were more likely to get CPR, less likely to have a pain assessment at the end of life. They're less likely to have a DNR order, less likely to have had a documented prognostic discussion. Even more data. This is in the UK. This is now in the outpatient setting. So this is COPD patients within primary care. Big data, again, this is an area of maybe 11 million patients, 674 primary care sites. They followed patients for a decade or so, and they pulled out 92,000 patients with COPD and 26,000 people who actually died from COPD. And they asked a similar question: what was the rate of palliative care service usage? And the solid line is the whole cohort. The dotted line is the patients that died from COPD. And the whole cohort one corresponds to this axis on the left here. And you can see over time, again, you still see that trend, which is nice to see. There's increasing usage of palliative care for pulmonary patients here. But again, if you look at these numbers, this is still 1%, 2% range, so extremely low. Now, the whole cohort of COPD patients might be different. Some are healthier than others. So if you look at the deceased patients, and that corresponds to this axis over here on the right. So the numbers are definitely higher. And you still see, though, at a peak, we're only talking about maybe 16% of patients who received palliative care services before they died. So, another way to think about that is to say 85% or more of patients who die from COPD died without any contact with palliative care services. The authors also looked at, for those who did have some palliative care services, of that small percentage, what time in their disease course did they receive those services? And not unexpectedly, you can see the majority of them cluster last 1 month of life, last 3 months of life. It really falls off at 6 months or so. And, we know that COPD patients they can certainly fall off a cliff quickly, but, their disease course is one usually of a slow trend punctuated by exacerbations, but, over years, they get sicker and sicker. There's gaps in advanced planning as well. So this is an old study now, but this is something that's cited a lot. This is about attitudes regarding advanced directives. It was done at a pulmonary rehab with people with chronic lung disease of all varieties. And there were 105 patients in the study, and 98%, pretty much all the patients indicated that they wanted to have end-of-life conversations with their doctors and they were ready for them. And only 19% actually had the conversations, and less than half had completed advanced directives. So, I would say there's obvious gaps in utilization of palliative care in this population. On top of that, some of these gaps, not unexpectedly in healthcare, these gaps become more prominent if you stratify by things like racial constructs or income. And so this is a table back from that first article on COPD admissions. And, they looked at different race constructs here. And so white is the comparator here, which is why it all says 0. I think the odds ratio should probably read 1 here as the comparator, but people they identified as Black race, 17% less likely to have received a palliative care referral. People Hispanic race, 32% less likely to have received a palliative care referral. And then same idea with income. So quartile 1 is your lowest quartile. This is your comparator. Odds ratio should say 1 there. And then as you have increasing income in quartiles 2, 3, and 4, you have a 19%, 20%, 41% increased likelihood of having had palliative care services. Now, on top of that, I hope a takeaway today is to understand that all of these chronic lung diseases are actually very highly symptomatic conditions also. It's estimated that pulmonary patients experience, on average, something like 14 or 15 symptoms. And there's data for this too. So this is a study that was done in Ireland. 214 outpatients with COPD, they sent them surveys and asked them to tell them about their symptoms. And you can see this chart is huge. This graphic actually is cut off because it wouldn't fit on the slide. The chart kind of keeps going on and on. And, there's pulmonary symptoms, and then there's tons of non-pulmonary symptoms as well. So just reading off some of the non-pulmonary ones: lack of energy, dry mouth, worrying, feeling drowsy, feeling irritable, other types of pains, feeling nervous, feeling sad, difficulty sleeping, numbness, tingling, swelling, concentrating, headaches, sweats, etc. It feels like this is a list of every symptom you could think of, and it seems like patients experienced a ton of these. And if you look at the numbers, these aren't trivial percentages either. They're mostly double-digit, 20, 30, 40% of patients have a lot of these symptoms on average. This is a study from the Mayo Clinic. Similar, but this is in pulmonary hypertension patients. So 315 patients they sent surveys to and asked them the same question. Again, similar results, a lot of symptoms being experienced by these patients. This one I'll point out here, fatigue is the second one, almost as prevalent as shortness of breath in this patient population. And then a lot of similar ones, drowsiness, pain, bloating, depression, anxiety, flushing, leg swelling, lots of different symptoms. This is idiopathic pulmonary fibrosis. So this is a registry from Finland, 245 patients. They mailed them surveys and you see, similar results, a lot of different symptoms experienced by all these pulmonary patients. Now, this paper discusses symptom clusters. Symptom clusters are pretty much symptoms that tend to be present with each other in groups. And I think, there's definitely some sort of common pathway with pulmonary disease here. So there's clusters like emotional clusters, insomnia, depression, anxiety. And we saw in all those figures, all the pulmonary patients, different physiologies of pulmonary hypertension, idiopathic pulmonary fibrosis, very different, but they seem to have some commonalities in the symptoms that are experienced. So, for the palliative provider, while it's probably useful to have some disease-specific knowledge of these, it can be helpful, but at the same time, the thought is that they probably experience a lot of the same types of these clusters. And I would really emphasize this emotional cluster. I think that's something we see a lot. I see a lot of, I've heard a lot of it. And, I've only recently been starting to understand it a little bit more when patients or their caregivers tell me about that. And it's, I hear the same thing as social withdrawal, social isolation, and then depression, anxiety, lots of fatigue, insomnia. So I put a lot of quotes here. And I put them all in because as I read them, they're all talking about the same theme. That's that emotional cluster of symptoms, that psychosocial cluster. So, they all start sounding really similar. We often feel very lonely. We're worried all the time. I'm always depressed. You don't have a social life. You shun away from all your friends. Now, on top of that, this is a pretty interesting figure from something called the COPD mirror study. And this was comparison of patients' views and what the physician's views are on the patient's quality of life. So this was COPD patients, separated out mild and moderate and severe, very severe disease. And they asked patients to rate their quality of life, daily activities, work activities, etc., on a scale from 1 through 5, with 5 being the worst. And then they asked their doctors to rate what they thought their patient experience was. And you can see in this mild moderate group, they actually cluster pretty decently. Some of the guesses were pretty close from the physicians. But then when you look at severe and very severe patients, you start seeing that spread a lot more, right? So orange dots here are what the patients rated their quality of life at. The green triangle was the pulmonologist, and then this purple diamond is what their primary care doctors thought. And so, you see a fairly consistent trend here in which there's a spread between how we think this disease is affecting their lives and how the patients experience it. And then finally, here's something this is a review of palliative sedation and end-of-life care. This is a 30-year review that was done recently. 11 different articles, 600 different patients who had sedation. And you see, dyspnea is right there at number 2 as most common refractory symptom in patients having palliative sedation. This is just like a campaign that was out by a group called the Lamb Foundation, a cystic lung disease that affects young women. And again, along the lines of the patient narrative, I thought this figure was interesting. That description, that quote from her: "The air I breathe is determined." So if I had to summarize that first section, what I would say is lung diseases are highly prevalent. They're, 3rd or 4th leading cause of death in the US. There's, underutilization, under-referral for services of palliative care. And on top of that, they're highly symptomatic conditions. And, and we also tend to underestimate how they affect patients' lives. So switching gears a little bit, wanted to talk a little bit about treatment options for these patients from a palliative care perspective, focusing on dyspnea. And now, when I think of the treatment options for dyspnea, a few options come up most frequently. I think of, fan therapy. I think of, we talk about deep breathing exercises a lot, and then we talk about opiates, of course. Now, in honesty, when I first was learning about some of these treatment options for dyspnea, I was kind of, it felt a little underwhelming, a little unsatisfying for me, to be honest. And I would say, especially if a patient can't take opiates for whatever reason, say they have substance abuse, active substance abuse, or prior substance abuse, or they have personal reasons not that they don't want to be on opiates, or maybe a true allergy, then it seems your treatment options become pretty slim. And I think that speaks to how difficult dyspnea is to treat, actually. But in light of that, I wanted to dig in a little bit more, partly for my own education, about some of the evidence and some of the options that are available for treating dyspnea. And I kind of went down this rabbit hole of evidence of opiates, and that was, where I want to start. And it was triggered by this article. I'm not sure if people saw this. This came out about 6 weeks ago in JAMA, the effective regular low-dose extended release morphine, chronic breathlessness in COPD. This was done at 20 sites in Australia, 156 patients with COPD and severe breathlessness. They were randomized to placebo, morphine at 8 milligrams, and morphine at 16 milligrams. And, this turned out to be a negative study. I'd say a very negative study. There's not really any trend that they see whatsoever there between 8 milligrams, 16 milligrams as far as breathlessness. So, this kind of caught my interest a little bit. And as I was reading this article, even in the background intro section, it references that a lot of the data on opiates for dyspnea is based on a lot of small trials that have existed for years, and that there's really a need for bigger trials. And so, I had previously kind of reflexively thought dyspnea and opiates for sure, they definitely work. And so I kind of was digging into the data a little bit more. Up until 2002, there was just a collection of small studies. It wasn't until 2002, Jennings et al., they did the first meta-analysis, and they pulled together a handful of studies. And they found a significant benefit for opiates in treating dyspnea. And so this was the main sort of compiled data that existed at the time. And you can see, if you look at these forest plots from the meta-analysis, these are all the individual studies here. You can see pretty wide error bars. Some of them have a trend, they're not statistically significant, but when you pull them together, you find this significant result. And so this was the best evidence at the time, and for 13 years or so, it remained the best compilation of all these small studies. Various small studies continue to come out. 2015, 2016, there were 2 more meta-analyses that were done independently. And they actually found the same result. There was a statistically significant benefit they found from opiates. And this is the 2016 meta-analysis. You see kind of similar things. A lot of trends, some of them not reaching significance, probably underpowered, but then when you put them all together, you see this definite result. So I would say for the last 2 decades or so, for the 2000s and 2010s, this has been kind of the dominant body of knowledge and evidence for opiates and dyspnea. So many different small studies, 3 separate meta-analyses that all had the same results. So the results were pretty consistent, and I feel like it's become fairly well established and accepted up until recent data came out. But the data was not bad for what was available. Now, if we take a little sidebar, a little kind of tangential, the next question for me is sort of, what is the effect size? So how well do the opiates actually work? I think that's something we hear a little bit less about. So if you, in these meta-analyses, this is the pooled result here, and they'll give you a little number here. This is negative 0.40, negative 0.32. That's called the standard mean difference in the meta-analysis. And so here's the SMBs for each of the meta-analyses. And again, these are compilations of several studies. And this is the range that each of the meta-analyses found. So these SMDs can be correlated with effect size, roughly in this fashion. So in general, something like 0.2 is considered a small effect size, 0.5 is moderate, and 0.8 is large. So, I would say on average, the effect size in each of these analyses was actually relatively small to moderate at best. And I think that's really interesting to point out. I don't think we hear about that as much, but it's important in the messaging for how well we think opiates actually work in breathlessness. Now, this second meta-analysis is 2015 one, in their discussion. They actually did some calculations to translate this SMD onto a clinical scale that is used often, this visual analog scale. And sometimes it's maybe easier to conceptualize looking at something like this. So this is the scale that patients will see. Essentially, it's a standardized bar, which is supposed to be 10 centimeters long, and patients should just mark on the line where their level of dyspnea is. And according to that study, so if you say we start here, this arrow is kind of arbitrarily placed, but the second meta-analysis, the effect size, this is made to scale with something like that. So an 8 to 9 millimeter change. Not the most robust change, but it's important to think about. Now, getting back to the studies, another thing that we've alluded to is that a lot of this data was based on small studies. Now, how small were these studies? If you look at the average number of patients per study, less than 20 patients per each of these studies, so 13, 18, and 19. So, while meta-analyses are really good at taking these small studies and compiling them together, at the same time, there's always been a call for larger studies to be done. And so there is new data now that I think needs to be considered in how we think about opiates. So, this is recent. This is just in the last 2 years or so, 2.5 years. Before 2020, I'm not aware of any bigger studies that were done. But Curl et al. In Thorax, in the journal Thorax, there was 284 patients, so much larger than any of the prior studies. And they took chronic breathlessness of all varieties. 2020, again, a second study came out in JAMA with 111 patients with COPD. And then in 2022, this is the study that just came out 6 weeks ago that we looked at, 156 patients with COPD. These are all morphine versus placebo. These are all multi-center double-blind randomized trials. And all of them found no difference actually in breathlessness. So these are all really interesting results. And I'm not, right now I'm not entirely sure what to make of them. So, the response to some of these trials has not really been, I haven't heard anyone saying, okay, we're throwing out all the prior 25 years of data prior to this, but it's definitely raised some eyebrows. There's been some various responses. For example, this first study, it's been raised, maybe there were some methodologic issues that made the interpretation a little bit tricky. The second study was actually technically reported as a positive study. So breathlessness was their secondary outcome. Their primary outcome was the significant improvement in the COPD assessment test. So they were actually saying there was a positive effect there. In this last study, I haven't heard a ton of critiques yet. All these studies were done decently, but it's raised a lot of discussion on, are there subgroups that we should look at? Are there different populations? And why does morphine maybe work for some patients? But, even we can look at this second study here, even this one. So they found a positive result for improvement in this COPD assessment test. So this is the study, again, it's in JAMA. 111 patients, morphine versus placebo. And here's their CAT score, and this is what they find. So you see a p-value, significant 0.03. You see a mean difference of negative 2.18. And so again, back to effect size, you should be asking the question, what does that mean? You have a significant result here, opiates do something in this study, but what is a COPD assessment test and what does that mean? So if you pull one of these up, they have them on MD-Calc. It's there's like 8 domains to it, and you can, there's cough, there's phlegm, there's how well can I walk up a hill, how's my sleep, how's my energy, and you can rate each of these domains 1 through 5. The total score on this test is 40. And so, if you think about a 2-point difference also there, maybe you go from 36 to 34, or 32 to 30. Again, these aren't necessarily the most robust changes. What about other medication options? So benzos come up frequently. There's a lot of data on that too. There's meta-analyses here. So This is another Cochrane review from 2016. And there's 200 patients compiled in these studies. And you can see all the individual studies here, pretty negative results. And I think most people accept that benzos do not work in the relief of breathlessness. So, I might take a little pause here and just have ask people, what they think about this data, and how that kind of relates to everyone's clinical experience and how that comports with, whatever your expert opinion on this is. Maybe in the chat, or if there's that time at the end for discussion. I think my personal experience just in the past 6 months, I've seen a lot of heterogeneity. I've seen a lot of variation in responses to opiates for dyspnea. So I've definitely had patients where you give low dose morphine, and after a single dose, I've had those patients tell me, I feel fantastic, that totally fixed my breathlessness. It works super well. And then obviously on the other side of the spectrum, we have patients who are on continuous infusions for their dyspnea of opiates, kind of teetering on the edge of palliative sedation. We have one of those now, actually. And so, why there's this huge heterogeneity, I don't know. I think what it boils down to is maybe, I think fundamentally we don't understand dyspnea well. Dyspnea is a really complex pathophysiologic process. It's got physiologic inputs, it's got different psychologic inputs, it overlaps with pain centers, and I don't think we know exactly how opiates are working on there. We're modulating some sort of pathways, but again, I don't think I've seen people do a full 180 on opiates based on some of these recent results, but I think in the coming years, we'll probably see a little bit more work honed in on, who's the right patient population to give opiates to, because I've seen it work for some people and do really good things. And for others, I think there's a good argument that maybe it's not working for other people. And, I think there's a lot of research and understanding dyspnea that needs to be done to figure those things out. Same thing with benzos, actually. I think, despite this data, I feel like I've seen there's a time and place for benzos, and I've seen them be very efficacious in some situations. And probably when anxiety is driving things a lot more than the dyspnea itself. But I would welcome people's experiences or thoughts on their experiences here. So some other agents to consider. Nebulized morphine comes up pretty commonly. And I think it's a good idea. And I think it's an attractive idea that people want to work. So the idea is that you can deliver some kind of localized opiate to the lungs and abrogate that sensation of dyspnea without getting potential for abuse and without getting possible side effects. But unfortunately, the data really hasn't played out for nebulized morphine. It's pretty consistently negative. There's a lot of meta-analyses that include studies on nebulized morphine, and I would say fairly consistently those studies are negative. I've heard a pharmacologic response and explanation to why that is. So I've heard that the ability for a medication to be absorbed through an inhalation route relates to its lipophilicity. And so morphine is not very lipophilic, but fentanyl is. I'm curious, I haven't seen many people using nebulized fentanyl. It's mostly case reports, maybe some smaller studies, but I've seen kind of mixed results there. More so this slide, again, I'm just curious if people have any experience with these. Nebulized Lasix is something that comes up. This has been around for years, and I think there's been a lot of interest in it. Some people have really good experiences. I would say the data looks mixed to me, and I would kind of leave it at that. But I do know I saw at least one, I think I saw a commentary on it from Daryl Owens even a couple of years ago, and so I'd welcome any thoughts there. Buprenorphine, I think, is a really interesting one as well. Mostly case reports, but it's the same idea. Can you get some opiate effect for treating dyspnea, but then put a cap on things like potential for abuse and possible side effects? But I would say that's really in its infancy. I've only seen case reports there. And then SSRIs have come up a bunch, and also I would say studies are mixed there. I suspect you're probably treating the depressive, psychosocial, anxiety type components of dyspnea with SSRIs, but again, that's fairly mixed. So here's a study on nebulized Lasix, just for fun. So this is the setup. This is a person here, and they hooked up healthy volunteers to this device that could introduce carbon dioxide into the circuit to create the sensation of air hunger. And then there was a resistor on the circuit that they could make it harder for a patient to breathe. And then they gave people nebulized Lasix after creating that environment. AH is air hunger. They actually saw pretty dramatic changes in the sensation of air hunger and dyspnea. This is a visual analog scale like we saw before, 2 centimeter, 3 centimeter changes in some of these patients, and then a dose response also. So second dose created a much larger response. Again, this is healthy volunteers, but just something interesting to think about. Again, I would say the data is pretty mixed. Now, moving into fan therapy really quickly. So fan therapy, again, this was on the spectrum of things that I thought would be unsatisfying when I was first learning about options to palliate dyspnea. I think I probably said, like, seriously tell patients that for their, crippling dyspnea, go get a fan and fan yourself. And if that doesn't work, maybe use some opiates. But I would say, I wanted to talk about this because I would say if I'm a little bit less certain about opiates, if anything, I would say I'm fully bought into fan therapy. So I think everybody should get a fan, and my takeaway would be, don't forget about the fan for people. So first of all, it's a low cost, low risk intervention, very cheap, pretty much no harm to it. And then there's actually some decent evidence for fan therapy too. So this study here, I put meta-analysis in quotes because they only ended up with 2 studies, but I kept it in here because you can see these effects are, both of these studies are pretty consistent with each other. Error bars are not huge. If you look at the SMD we were talking about before, 0.2 small, 0.5 moderate, 0.8 large, a pretty large treatment effect for fan therapy. This is a survey, 133 patients. 70% of people thought the fan was beneficial. An additional 10% on top of that said very substantially beneficial. 80% had a really good response. 15% were uncertain, and then only 5% really said definitively no benefit. So potentially 90+% of people have some benefit with fan therapy. This is another study that used that same visual analog scale, and they saw results that were probably comparable to what the opiate results were, about 9 millimeters of change. And then lastly, talking about deep breathing exercises. So deep breathing exercises are great. I think we love deep breathing exercises, and we know they're in the treatment algorithm of what we should do and how we can palliate dyspnea for folks with refractory breathlessness. I am always curious what people tell their patients and how they guide them through this. And I feel like when I ask, this is the type of usual response I get. So almost always it's pursed breathing, sometimes something else, and then sometimes confused too. And I would confess from my own practice, from my pulmonary clinic days, right, when I think back, I would say I didn't do a lot of deep breathing exercises with patients, and I try to think back why, as somebody who's interested in palliative care. And I think pulmonary clinic is busy like other clinics in general. There's a lot of other stuff you're trying to do. You're doing PFTs, you're doing the inhaler technique, you're talking about different results, you're talking about lung cancer screening, et cetera. And so, I've noticed that it can kind of fall through the gaps a little bit, even though it's one of the main things we talk about in palliating dyspnea. And so, I actually asked a bunch of other POEM fellows too, kind of past and present POEM fellows, and I get similar responses. I don't, it's not something I think people do very regularly, even though, here we're an institution where we care a lot about palliative care. It's, maybe in the community where it's a lot busier, that there's not a lot of time to do that. And I think there's a lot of uncertainty as to who is doing these types of things. I've heard people say, oh, do they do that at pulmonary rehab? And, I'm not sure if they do. But a lot of our patients also can't go to pulmonary rehab. So you need insurance. You need to be able to travel to get to pulmonary rehab. The sites that we have at UW, there's nothing in the UW system. We have Northgate, and then we have Valley for pulmonary rehab. So they're hard to get through too. A lot of people can't make it. I've heard people maybe raise, well, maybe rehab psychology is a good option for that, but I've never really been able to get somebody a rehab psych appointment either. So, all that to say, I think as palliative providers, I think, if we put this squarely in our domain as something we actually talk through patients with, I think it would serve a lot of good and some unmet needs there. I've heard people say they refer to Headspace too, and so I'm curious what resources people actually use for this. So I did want to talk through a couple options just so we've heard some of these things. First is pursed lip breathing. Again, I think everybody seems to know that one pretty well. The second one down here, recovery breathing, I think is important. This is something I think should be in everyone's wheelhouse as palliative providers. Because, this is if your patient's in crisis, it's kind of like an action plan. What do you do? This is a really good resource here, this website. We'll talk about them a little bit later, but they also talk about the 3 F's of recovery breathing. And so that's fan, this forward lean position, and then focusing on your breathing with long or relaxed exhalations. Now, this forward lean position is kind of called recovery position. You see in a lot of these kind of bent over like that. And I actually think there's some physiologic basis there. If you think about when people tripod, it's the same idea. I think what you're doing is, you're kind of stabilizing your shoulders and your core and allowing your body to kind of utilize your accessory muscles of respiration a lot easier. This website also talks about, there may be different recovery positions. So there's a variety that they offer here. You can tell your patients to maybe try out a few of those, but it's essentially like an action plan. And I think it's important if we're talking about breathing exercises for patients who have chronic dyspnea. This one in the top right here, this is belly breathing. I think most people know this one also. It can be done upright, or this can be done supine. The main idea is during inspiration, you want to feel your belly expand as your diaphragm moves down. And then belly in as you breathe out. And again, these are slow, controlled breaths, usually a focus on the exhalation phase. And down here, this last one is, it's called square breathing. Actually more of a rectangle. It doesn't have the same ring to it exactly, but there's YouTube videos of this, or there's a square, and then there's like a light. There's a visual analog too that you follow along, and you tell your patients to breathe a square. So 2 seconds in. Sometimes I have patients, use their hands too as a visual guide. And there's some visual component that they identify with that helps control the breathing a little bit. So 2 seconds in, and then 4 seconds out. 1, 2, 3, 4, 2 seconds in. So these are a couple different options. And, as I was looking for good resources for this is another thing I would ask people, like, what do you do for this, or where do you send patients, or are there good resources out there? Because, honestly, I couldn't find good ones. I was looking at a bunch of random YouTube videos, and some of them, you have no idea what their expertise are. The American Lung Association has a few videos. They have a YouTube channel. It includes pursed lip breathing and it includes belly breathing. But I'm curious if other people have, referred people to good resources. Right now, it feels like it's a compilation of kind of scattered videos to me. Inspiratory muscle training. I might skip this for time. But here's another meta-analysis, another Cochrane review. This one's fantastic. So this is all non-pharmacologic interventions for dyspnea. So they looked at all these different interventions that people have tried, and they compiled it in a big meta-analysis. So acupuncture, music, relaxation, walking aids, chest wall vibration, apparently is something people do. Neuromuscular electric stimulation. This is like a TENS unit, I guess, that people can put on their thighs. Fan therapy. And then they also looked at multi-component interventions, so counseling support and case management and psychotherapy. And this meta-analysis is great. There was actually a bunch of these that showed a significant result, including this TENS unit-like thing, chest wall vibration. I think acupuncture was a little bit less, psychotherapy, relaxation training. And so, if you're trying to integrate all these different interventions now, your care model, your treatment algorithm, you can imagine your model of care becomes a lot larger when you're trying to do something multidisciplinary in this holistic, integrated way. Because, in the scheme of things, if, maybe it's that your opiates and your fan get you a little bit of effect, but they can only do so much, in my opinion, based on the data. But then you start integrating some of these other things, your deep breathing, your psychotherapy, and then you have this very large multidisciplinary type case management type care. And maybe then you start moving that arrow down the line a little bit further and maybe improve lives a little bit more. But, you know, this begs the question, if you have such a complex model of care that you're trying to deliver, where does that, you know, how do you do that? And it kind of segues into my last section here, which is about models of care, delivery models. So how do we do this, right? If you're trying to do all these complex therapies, you know, in what setting can you have this holistic kind of integrated view? And I think in this country, there's actually not a good model for it that exists. We'll talk about other models elsewhere. You know, here, you know, I think we're still at a phase of figuring out, you know, when should we be referring these folks to palliative care? There's still a lot of recognition and a lot of needs. And where should this care take place? So I want to introduce this policy statement. This is a joint statement from the American Thoracic Society with AHPM, Hospice and Palliative Care Nurse Association, and also Social Work and Hospice Palliative Care Network. So multiple agencies. This came out in May of this year. And there's a big author list, and this is cut off, but you know, the senior author on this is actually our very own Aaron Cross. And the goals of this statement, right, are to advocate for improved integration of high quality palliative care early in the care continuum for patients with serious respiratory illness and their caregivers. And it provides clinicians and policymakers with a framework to accomplish this. There's a lot of really cool stuff here, and I would direct your attention to look at it if you have pulmonary patients that you're seeing. This is one of the resources in there. This is like a guideline for when we should start thinking about palliative care, either primary palliative care or secondary palliative care, based on a lot of these different domains down here. So some just based on spirometry, some based on the symptoms patients are having, some based on, you know, how often they're in the hospital, are they on supplemental oxygen, definitely if they're needing a lung transplant. And it has thresholds for when we should think about primary palliative care and secondary palliative care. Well, this feels like something that could be disseminated for primary care providers. This is something that probably would be useful for pulmonary providers too. And, or if you're on an inpatient consult service and you see somebody coming in for hospitalizations, maybe you nudge the primary team and say, hey, you know, maybe this person should come see us in palliative care and follow up afterward. So this is something that's super helpful. Here's the rest of the contents of this policy statement. Let's put the whole contents here, but when it talks about these different delivery models, it gives you tools for symptom assessment. So how we manage or how we measure different symptoms for pulmonary patients objectively and how we can trend that. Guidelines on advanced care planning. There's an excellent section for caregiver support and caregiver resources here. This is a huge problem. We didn't talk about this at all, but this comes up all the time for caregiver fatigue. There's a section on health disparities there too. How do we use language, or how do we make sure we're being inclusive, especially knowing that palliative care accessibility is always less in underserved populations. There's this very interesting mass casualty segment there too, that I think came out of the COVID pandemic. And I remember being around in Harborview in the early days of the pandemic, and you know, there was MICU and palliative care working really well together in that phase. If people remember that, if they were there working overtime, but you know, people were all dying alone really early on. Palliative care was, you know, finding ways to get into these isolation rooms on iPads in the first couple of days of the pandemic. And so there's some guidance there too, which I think is really interesting. This is another resource from American Thoracic Society as well. That, you know, kind of been coining this term, the acute dyspnea crisis. And again, this is kind of emergent planning for your patients. So there's this worksheet here with this acronym COMFORT. And this is something that I would say you can do with your patients and fill out. In pulmonary, we do things like this, almost like asthma action plans. This is like a dyspnea action plan. And it focuses on, you know, medications. What do you do with your fan and oxygen, reassurance, et cetera. And then from a physician side, you can put a lot of resources here. And it's kind of like that other slide we looked at with, you know, kind of recovery position, recovery breathing. What do you do? That can be really helpful for patients. Now, these are the last few slides on this. If we want to think forwards a little bit, what direction can we move in? Can we ever get to this point of having this really holistic integrated care model to deliver all these complex needs that are probably needed to fully manage this effective dyspnea on people's lives? And so this is the website from the Cicely Saunders Institute in the UK, in conjunction with King's College London and the Cambridge hospitals out there. And they talk about, there's articles there about transforming the recognition and management of breathlessness. So I wanted to introduce, I don't know if people have heard about this before, but this what they call breathlessness clinics. And it's exactly what we've been talking about, this integrated care model. And in reality, they've been doing this out there for probably 20 years. Since 2004, they've had this model out there. And you'll see your pulmonary provider, and afterwards there'll be this multidisciplinary team that is palliative care, OT and PT, a respiratory therapist, and sometimes even a psychotherapist. It's really hard to get sometimes. But I won't go into the data, but a lot of this has been studied. They've shown clinical efficacy, they've shown patient satisfaction, they've shown cost efficacy. So it's a really interesting model, and for some reason hasn't translated overseas super well. It has spread to other countries. They now have them, I think, in Australia, Germany, maybe a few others, but I don't think there's a model that currently exists in the US that is similar to this, but maybe it's something we can aspire to. So some of my takeaways, hopefully we have some time for discussion or questions. So I would say, one, pulmonary diseases are highly prevalent, high burden on symptom-wise, and a lot of ongoing unmet palliative needs. For some reason, there's some lack of recognition still there. And I would say there are actually a wide array of non-pharmacologic and pharmacologic options for dyspnea, definitely emphasizing non-pharmacologic. I'd really, my takeaway from some of those opiate studies are, I've seen what I've changed is I've really started to curb back my language a little bit. I don't think I would say that, the evidence is totally against opiates now, but I've definitely modified what I say to patients. And so, maybe 4 months ago, I would still be telling people, oh, I think opiates can work really well for you. I've curbed that back a little bit personally to something more along the lines of like, morphine may help you. It may help some people. It may take the edge off a little bit. I don't think it's going to take away your sensation completely, but it may take the edge off a little bit so you can focus on X, Y, and Z. And I think most of the studies would suggest that there's only a small or moderate benefit at best. This was a big takeaway for me too. The lack of appropriate settings, I think, is a barrier for translation of a large body of research. So as I was putting this talk together, one thing I found was that there is actually tons and tons of research out there in this field. So, we have all those studies characterizing everyone's symptoms, all these studies on opiates, other electric stimulators, chest wall vibrators, inspiratory muscle training, pulmonary rehab, case management, psychotherapy. There is a ton of data out there, but it feels to me like translating that into really good care delivery maybe is limited by the models that we have. But the fortunate thing is, I would say that there's guidelines that are being developed. There's frameworks that are being offered if people look for it. And there's even, a really good model that exists overseas that's been there for 20 years that maybe one day we can implement. So that's my last slide. I have, I'm supposed to put this QR reader here for evaluations. And then otherwise, thank you for your time.
Thanks, Cliff. That was wonderful. I think you brought up so many good points that I think some of us were aware of and some of us weren't. And I think it's always easy to have a medication that you can throw at a symptom or a problem, and all the other evidence-based and wonderful interventions that might actually make a difference in the US healthcare system, I think we see as so hard to implement because they do often involve this more holistic care and interventions that maybe we can't, I mean, try finding a fan at Harborview for one of your patients. I got laughed at once when I asked if we could get one. Okay, so I will turn your attention to some comments in the chat. First of all, a number of comments, just great talk. David has a comment and question, but was wondering whether patients, I believe in that first JAMA study that you were discussing, reported improvement with placebo.
I think in that study, it was a very negative study, but I have seen other studies in which there's definitely some improvements with placebo. I've noticed that with a lot of nebulized medications. So I've seen nebulized saline as the placebo for nebulized fentanyl or something like that, nebulized Lasix. And I've seen, you do see some placebo effect in that, which is curious.
And then Lauren Pollock said, I've always thought it was odd that the hospital fans are typically mounted behind the patient's beds, so they don't get any of the airflow. Missed opportunity. I agree. I mean, it seems like sometimes our hospitals are, well, probably logistically were designed back in the 60s and 70s, so not always with these things in mind. And then David shared that some patients with severe COPD discover pursed lip breathing and tripoding on their own, which I agree I've seen as well. Our patients are oftentimes very resourceful. John is asking, is there any work on the use of ketamine, particularly oral low dose for breathlessness in patients with COPD?
Interesting. I don't know. I don't know of any actually studies for that. I think in the pulmonary world, in the critical care world, we use ketamine a lot because it doesn't, it's not supposed to have any respiratory depressant effects. And if anything, it might be a little bit of a respiratory stimulant too. And it's interesting, its neurologic effects, how that might modulate breathlessness. I would say, one side effect of ketamine that can come up is, it increases secretions a lot, and that can be oral secretions and bronchial secretions. So, that might be a limiting factor for some of these folks who may already have tons of mucus production. It's possible. But I'm not aware of any. It'd be really interesting.
Well, you did a great job with the time, Cliff. There's time for a last question or comment if anybody wants to unmute or raise their hand. Otherwise, I think we'll wrap up. Great talk, Cliff. I wonder, I do wonder if we've just kind of been resting on, our comfort with, morphine can help with, or opioids can help with dyspnea. And nobody's really sought out newer pharmacologic options for dyspnea, potentially more effective options. It seems like it's wide open for opportunity, but dyspnea is something that's just notoriously hard to treat. I think simply pharmacologically, I think, you definitely demonstrate with your talk that like pain, total dyspnea, you have to treat many things. And David has his hand up, so.
Yeah, just one other comment. As with many things, if we can identify underlying specific causes, wheezing, bronchospasm, volume overload, mechanical factors like ascites that affect the ability to take a deep breath, those kinds of things. We're always looking for those things.
Yeah, I totally agree. I think, there's an assumption with all these kind of last resort things and opiates that should obviously be looking at, are there any modulatory things you can still modulate in the care? And is there simple things even like nebulizers or of course a prednisone that can help somebody?
Well, thank you again, Cliff. This was a really great talk, and it'll be available on our website. So thank you everyone for joining us this morning.